Okay, hello everyone. I'm Jefferson Headache Wu from the Taipei Regional Hospital and also the chair of the communication committee of the IHS. And today we invited Scott Yan to talk about the new treatment strategy, which is called the embolization of middle meningeal artery to treat migraine. So, could you please to introduce your research findings or your proposals?
Yes, hi. Thank you for the invitations. So we started recently. We collaborate with our neurosurgery group and also Johnson & Johnson. We started a project looking at the effect of middle meningeal artery embolization for the prevention of refractory chronic migraine. So this idea actually originated from several observations during the subdural hemorrhage treatment, and they found that after the middle meningeal artery embolization, some of the patient headache got improved. So in this case, we want to see if this procedure can help reduce the headache in refractory chronic migraine patients.
Okay, so one question is that what is the possible mechanism or rationale behind this protocol?
Yes, that is a very good question. Right now, everything is speculative. However, we do believe that when we embolize the middle meningeal artery, some of the vascular and trigeminal nerve interactions can be obstructed. We all know that there are CGRPs on the trigeminal peptidergic sensory fibers. However, there are interactions not just the nerve to the vessels, but there are also some vessels to the nerve, which can potentiate the effect of the CGRP. In this case, we don't believe it is a complete obscuration or complete annihilations of the blood vessels that cause the destruction of the nerve. We believe is somehow affecting the interaction between the vessels and the nerve that causes the overall reduction in the CGRP as one of the mechanisms. Because honestly, we don't have a good answer right now, but that's what our speculations.
Okay, I have one question about your protocol. Could you possibly to explain the embolization of the middle meningeal artery in detail? For example, at which timing or which location to do the embolization?
Yes. So this procedure is typically done by our endovascular neurosurgeons. So we select only patients who have failed at least two commonly used preventive medications, but also have to fail either CGRP or Botox. So these are the refractory patient populations. And then for these patients, the neurosurgeons will put in the catheter in near just slightly above the origin of the middle meningeal artery areas, and we try to avoid these glue can go to the ophthalmic artery. We try to avoid these going to damage some of the hearing areas. So we have to go distal enough, and the glue will be injected all to these areas. Try to create a blockage effect of these vessels. It's not entirely occluding the vessels, but this glue will go to the terminal arteries and creating some kind of a stunning effects of these arteries. And of course, but they want to make sure it does not cause vision loss or cause any hearing issues.
That sounds great. And I have one question regarding the well-known CGRP therapy in migraine. Do you think this treatment strategy is to prevent the release of CGRP or the inhibition of the downstream pathway of the CGRP mechanisms?
So this is another very good question. So far, we don't know. Again, everything is speculative. Whether the CGRP level will be increased or decreased after this procedure, so far we don't know. So we are still in recruitment. There are several sites in the United States collecting this data. We very carefully. We understand that some places are already doing this by themselves, but we are following a very strict protocol to make sure we're not creating more harm to patients.
Another question is that regarding the sidedness of the headache, does the patient should receive the bilateral embolization or only the embolization over their most frequently attacked site?
Yeah, right now we're doing the both sides. Yeah.
Okay, so in your experience, which kind of patients were suitable to receive this type of new treatment strategy?
Yes. Usually, we reserve this procedure to those who have failed several existing medications. So they have to. They don't have a major secondary issues. They cannot have a major psychiatric issues, but they still have persistent headache, daily headache, or more than 24 headache days per month. Yes, these people who have failed multiple drugs can be a candidate for this kind of studies.
Okay, thank you for your comprehensive introduction for the new protocols. See you next IHC.
Thank you so much.